that first part. Let me go back here. So we talked about the structures it has to go through. Surface area and time are two of the big factors involved. Normal transit time is about 0.75 seconds. Normal diffusion is 0.25, so there's adequate amount of diffusion happening. You can see that you're predominantly here, the time spent in the capillary. By the time a quarter second goes by, you've almost combined to your, or equilibrated between your alveolar PO2 and you're dissolved in the bloodstream. It's only during exercise that the problem comes up. So molecular weight is one factor. That's Graham's law. It's inverse to the square root of the molecular weight. But the solubility of coefficient is the more important factor to remember, because the solubility is how easy it dissolves into the blood, Henry's law. How quickly it moves through the blood is Graham's law. But it's really the solubility is the key that is involved here. And the CO2 has a profoundly greater solubility than oxygen, which is why it diffuses 20 times across the AC membrane. Implication being is that you end up having, you'll see hypoxemia long before you'll see hypercarbia. And if you look at the driving pressures of the individual gases, looking at what's in the alveolus versus what's in the pulmonary capillary, very small change in CO2, very profound change in PO2. And this is just kind of showing the same thing, PO2 of 102 in the alveolus, PCO2 of 40 in the alveolus, and by the time the blood passes through, and accounting for some venous admixture, we end up with our arterial of 90, mid-90s, 80 to 100, basically, and our CO2 somewhere about 40. And there's the components. We talked about surface area being a requirement. There's also a factor as far as the diffusion constant, which is what makes up the Henry's law and Graham's law. Gas diffuses because of the pressure gradient. Bigger pressure gradient, more diffusion will end up happening. And the thickness of the membrane. Two biggest ones that we concern ourselves with are the area and the thickness. Area in the sense that as I lose lung volume, I have a reduction in diffusing capacity. So emphysema patients have a reduced diffusion simply because they lost their surface area. Pulmonary edema patients have diffusion defects simply because of the thickness of the membrane. There we go. That's what I just said. So that went well. Normally, we're talking about a very minor thickness that is involved. The presence of pulmonary edema, as I said, or pulmonary fibrosis leads to a reduction, or I'm sorry, an increase in diffusion time. It takes longer to get across. And in the face of normal cardiac output, that's not an issue. But when the patient has an increase in cardiac output with a reduction in transit time, you would end up having hypoxemia manifested. So this is why patients with diffusion defects are fine at rest until they get up to do something, walk across the room, and then they become short of breath. Driving pressure, unless you're in a situation where you have a low barometric pressure, probably is not going to be something that you're going to manifest in the ICU. But in those instances, if you were to travel to a high altitude place, barometric pressure lower, inspired PO2 lower, alveolar PO2 lower, you're going to experience dyspnea with mild exertion because you're not having adequate amount of oxygen in the alveolus. And we just talked about this. Septic shock, as we'll find next semester, septicemia is manifested by a hyperdynamic cardiac output. So you end up having cardiac outputs of 10, 12 liters per minute. And in that case, same kind of process will end up going through, that you may have an inadequate time for equilibration because of that shortened capillary transit time, and you end up developing hypoxemia. Surface area we talked about. Things that would reduce the surface area include removal of a lobe, removal of a lung, and especially in our emphysema patients with the development of blebs and bullae. And that's really the first sign that they end up having is that dyspnea on exertion, the DOE. At rest, they're pretty well normalized. This is why we do that 6-minute walk test, not only to see the distance that they're able to accomplish, but also to evaluate with pulse oximetry their desaturation, because that then becomes an indication and a justification for Medicare reimbursement. So even though their saturation may be fine at rest, when we walk them, we see the desaturation happening. And we measure this with the diffusing lung capacity, normal value being 25 milliliters per minute per millimeter of mercury of carbon monoxide. We'll talk more. 25 millimeters of mercury, 25 milliliters of oxygen diffused for every millimeter of mercury. 25 milliliters per minute per millimeter of mercury of carbon monoxide. And we'll talk more about diffusing capacity when we cover it towards the end. We go through some advanced pulmonary diagnostics. I know you're all excited and can't wait to get back to the lung box. And that's it. So